Broadcast is now starting. All attendees are in listen-only mode.
Good morning. This is Anna Davis with the Oregon Health Authority. We're going to wait just a couple minutes before we kick off our nurse staff and complaint process webinar so that more people can join and get through the GoToWebinar. So we will have silence for just a couple more minutes. All right, thank you for waiting. This again is Anna Davis. I'm the Survey and Certification Program Manager with Healthcare Regulation and Quality Improvement here at the Oregon Health Authority, and we are the team tasked with running the nurse staffing survey and complaint investigations all across Oregon and supporting the Nurse Staffing Advisory Board. Before I let Kimberly introduce herself, I am just going to say that the Nurse Staffing Advisory Board has their quarterly meeting next Wednesday at 1 p.m. And if you want more information, those meetings are open to the public. It'll be held on Zoom, and you can find the board packet, and that includes the link to the meeting on our website, healthoregon.org/nurse-staffing. And with that, I'll pass it over to Kimberly.
And hello, I'm Kimberly Volker. I'm the Nurse Staffing Policy Analyst for the Oregon Health Authority. It is a pleasure to speak with you all today.
All right, so we're going to launch right in and go over the topics we'll be covering today. As usual, we're going to start with a description of the complaint process. Then we'll have a whole section on the information that needs to be submitted when you submit a complaint, and that includes additional specific information for certain types of complaints. Then we'll move into our section on nurse staffing myths exposed, focusing this week on the complaint process, and then Q&A, where we have some early bird questions, and we'll take your questions that you can put into the question section of the webinar anytime during the webinar. And then we will list out that last webinar that we'll be hosting next week, and finally link to our resources. So with that, I will pass it to Kimberly to start talking about the complaints.
Absolutely. And before we get started, I will say that email address, or not email address, excuse me, that web link address that Anna was mentioning is now posted in the chat. That is where that link and agenda packet is for that Nurse Staffing Advisory Board meeting if anyone is interested in attending that next week. So jumping into nurse staffing complaints. So anyone can submit a complaint alleging violations of the nurse staffing rules. Some common complaint areas that we see are complaints about nurse staffing committee composition and operations, failing to develop or implement a nurse staffing plan, failing to staff in accordance with the nurse staffing plan, failing to provide meal and rest breaks, which does fall under a subset of that nurse staffing plan requirements, and requiring nursing staff members to work mandatory overtime. Our complaint process and those requirements for them are described in Oregon Revised Statute 441.171 and Oregon Administrative Rule OAR 333-501-0045. We can move on to the next slide.
Oh, sorry. There we go.
So right here, what we have is a graphic showing what our complaint triage process looks like. So we start off with that first box there, and that's when the nurse staffing complaint is submitted to the Oregon Health Authority. At that point, the Oregon Health Authority, conducts a review of the complaint to identify subject area and additional information necessary for our hospital complaint triage team to triage that complaint.
I'm going to jump in and say, who's on the triage team?
Our hospital surveyors are, you are, I am, and we do have some administrative specialists as well.
And we also have surveyors from other program areas. They're all nurses. All of our surveyors are nurses. So we get a wide variety of perspectives and great additional questions and discussion.
So once we get that additional information necessary to have that complaint go to the triage team, the complaint is sent to the hospital complaint triage team, which we then review it together to determine what action we are authorized to take. One of two things may happen from that meeting. We may come to a determination on it, or we may decide, you know what, we still need more information. That's where that arrow is, and it's pointing back to OHA getting that additional information. So if that's the case, we would go back, we would get additional information, and then again, read it back to the triage team. That's option one. Option two is we are able to make a determination, and in that determination, it can go really one of two ways for nurse staffing complaints. We may have that complaint be within our jurisdiction, in which case we would be authorized to complete or conduct an unannounced complaint investigation, or we may look at it and determine that those allegations really are not within our jurisdiction and we are not authorized to act on it. Regardless of what we determine, we will send a letter to the complainant describing our next steps and whether we can investigate the concern or we will be closing the complaint without investigation. If the complaint is within our jurisdiction, we then conduct an unannounced investigation of the hospital, and OHA will send the hospital and the complainant a copy of the investigation report. The hospital is then required to correct the deficiencies described in the report.
In addition to sending out those copies of that report, we also post the report on our website, which again is in the chat. And that plan of correction, when a hospital submits a plan of correction and the plan of correction is approved, that also gets posted with the report on the website.
So we're going to talk about that investigation process a little bit. Complaint investigations are unannounced. That means we do not inform the hospital of any complaints. We don't tell them about the existence of any complaints until we initiate the investigation. We also do not inform complainants of the date that we will conduct an investigation.
And even when we go and we do, so when we go and we start that investigation, you're going to get into confidentiality. The hospital never gets to see that complaint.
Mm-hmm. And that gets us to our next point. The identity of the complainant is confidential. We do not disclose the identity of the complainant to the hospital, like Anna's saying. They never get to see that complaint. And for individual focused complaints, such as missing a meal or a rest break, or someone saying, I was required to work mandatory overtime, we select a sample of similarly situated nursing staff members, the records to review along with the original complainant incident to help mask the identity of the complainant.
I will say, this is the lawyer fine print. We keep the information about the complaints and the complainant identity confidential to the extent permitted by law, and there are limitations on that because these are state complaints. Federal complaints actually have a different sort of protection that we don't have at the state level, but we do our best to keep those confidential in all situations.
Our last thing about this investigation process are that those complaint investigations have a narrow scope. So when you think about the surveys, those full nurse staffing surveys, we're really going to evaluate all of those requirements through record reviews, attestations, interviews, everything's getting looked at. For complaint investigations, we're really investigating the rule area relevant to the complaint. So if it's a complaint about meal and rest breaks, that investigation is going to be focused on meal and rest breaks. Violations outside of complaint allegations, we're not going to be looking at those other rural areas, but if incidentally during the course of the investigation we happen to see that those other areas are also out of compliance, that is still going to be cited if we incidentally discover that.
For example, if we were looking at meal and rest breaks, we wouldn't generally be looking at nurse staffing committee operations, but if we learned during the course of our investigation that the nurse staffing committee hasn't met in a year, we would be citing that.
So complaint investigations may be combined with full surveys or other complaints. And like we mentioned, that investigation report is sent directly to the hospital administrator, the chief nursing officer, and both nurse staffing committee co-chairs, so both the direct care co-chair and the nurse manager co-chair. We also send a copy of that report privately to the complainant. And that report indicates whether the complaints were substantiated or unsubstantiated. And so, meaning essentially that, did we see during the complaint investigation, was there documentation to support the allegation, or did the documentation not support it, or we just didn't have the documentation to support the allegation? So if the investigation reflects that there is non-compliance with the nurse staffing rules, the hospital must write a plan of correction to address the non-compliance. That plan of correction must address how the hospital will be in compliance for all units and not just the units cited in the report. So let's say we've got a complaint investigation focused on the OR, and we see non-compliance in the OR for meals and drinks. We're going to stick on that one. That the hospital needs to write a plan of correction that addresses not just the OR, but also med-surg, ED, any of those other units where they have nursing services provided. So we are just showing here those complaint forms. There are 2 complaint forms that we have. We have that complaint intake form. It's number 1 on the left. You're seeing the first page of that. That is one that we use for all of our facility types that we regulate. So hospitals, home health agencies, hospices, in-home care, everyone uses that complaint intake form. And because of that, it's a lot more focused for individuals and patient care specifically. Because of that, we have developed a second nurse staffing addendum that's really going to hone in on those nurse staffing complaints. You see that on the right, and that is actually, I think, the second page, because the first page is an explanation of when it should be used and who it should be used by. Okay. Oh, actually, I almost forgot something important. Yes. Importantly, we have been talking about that healthoregon.org/nurse staffing. These complaint forms live on healthoregon.org/facility complaints. Our website does link to that, so if you get to nurse staffing, you will find your way here. We do have links that get you there, but you can get to them directly through healthoregon.org/facility complaints. All right. So there's some information that we need for all nurse staffing complaints, regardless of the focus area. First, we need the complainant contact information, their first and last name, phone number, email address, street address, which is needed for mailing the letter and the report, and their role at the hospital. We need this because we do frequently need more information about the complaints and about those incidents. And so we do need contact information to help facilitate that communication. We also need to know the name of the hospital, the units that are known to be affected, when the incident happened, and a brief description of the problem. That is information we need for any nurse staffing complaints, regardless of the focus area. We will now go into
I'm going to jump in before we even move on. I'm going to jump in and say, when we talk about when the incident happened, we need specific dates. So saying this happens all the time, we aren't going to be able to review all the time. So we're going to need, you can say it happens all the time, and then you need to say, and it happened on Thursday, October 20th, and Friday, October 21st during the morning shift. This is when it happened.
And I think one of the important things to keep in mind about this is when we do an investigation, we have to have a specific allegation. So something like, I missed my lunch break on the ED unit on October 19th morning shift. So we need to have a very specific allegation. We can't go to the hospital and just search around through the records looking for something. We need to go in for a specific reason.
We aren't going to be able to look at all of the records. So we need specific incidents so we can ask for those shifts to look at.
There's additional specific information that we need for different complaint types. The first one, and one that we do very commonly get complaints about, are minimum numbers. So the questions that we want to have addressed in those are, does the nurse staffing plan include minimum numbers, or does it have a ratio? And if you've been with us through the other webinars, you'll know that the nurse staffing rules do not include requirements about ratios. We cannot enforce staffing ratios. But if your plan has a ratio instead of a minimum number, that can be the basis of a complaint. If you have a complaint about the unit not meeting its minimum numbers, we do want 2 specific questions addressed. How many RNs, LPNs, and CNAs was the unit supposed to have according to the approved nurse staffing plan, and how many RNs, LPNs, and CNAs were actually on the unit. That information is needed for each date and shift reported where the unit didn't meet minimum numbers. So let's say you have a complaint about the 18th and the 19th. We would want to know how many were you supposed to have on the 18th and how many did you actually have. Same thing for the 19th. The additional specific information that we need for meal and rest break complaints. If we have a complaint where someone missed a meal or rest break, we need the first and last name of the person who missed a break. And if it is you who missed the break and you are the one submitting the complaint, a simple statement like, I am the one who missed a break is sufficient, but we do need it to be very clear who missed the meal and rest break, meal or rest break. We would need the date that the break was missed, the shift that the break was missed, and the unit that person was assigned to when the break was missed. If you have a complaint where the unit didn't meet its minimum numbers when someone was on break, we would need to know, this is very similar to the minimum numbers on the last page, how many RNs, LPNs, and CNAs was the unit supposed to have, again, based off of that approved nurse staffing plan, and how many RNs, LPNs, and CNAs were actually on the unit.
So for example, if your nurse staffing plan says for the morning shift, we're supposed to have 5 RNs and 2 CNAs, and the allegation is that, well, we had 5 RNs and 2 CNAs, but the minute someone went on break, we had 4 RNs and 2 CNAs, then that's what we need to see reflected in the complaint, what you were supposed to have, what you actually had, and when that was.
Yes, exactly. Another area that this could have for a meal and rest break complaint, but one that we do see slightly less commonly, is does the nurse staffing plan include a process about providing meal and rest breaks? So do you have a means to make sure that everyone's getting their breaks and you're not dropping below minimum numbers? Another area that we see complaints for are mandatory overtime. And this first question that we have is really that most important question for the mandatory overtime, and basically that first pass. Did you volunteer to work this time, or were you required to as a condition of employment?
And volunteer can mean they ask you, oh, please, will you? And you say yes, that's voluntary.
At that point, if you do agree, if you have the choice to say no and you say yes, I'm going to work overtime, that becomes voluntary overtime and we don't have a mandatory overtime complaint that we can work off of. So that is the first question that we need to have addressed for any mandatory overtime complaint. If we have, as an answer to that first question, yes, I was required to, I didn't get that option, I was required to work overtime, then we need to get into a little bit more specifics. We need to know which violation of overtime requirements occurred. Was that being required to work beyond your agreed upon and prearranged shift? Being required to work more than 48 hours in any hospital-defined work week? Being required to work more than 12 hours in a 24-hour period? Or during the 10-hour rest period following the 12th or more hour work in a 24-hour period? So we would need to know that. We would need to know how much additional time were you required to work? And to the extent of your knowledge, was there either a staff vacancy for the next shift that became known at the end of your current shift, or potential harm to a patient if you left your assignment or transferred care to another nurse?
And again, that's for that 1 hour exception, up to 1 hour of work. Anything more than 1 hour, neither of those exceptions would apply.
Now, if you have this situation where you're working, let's say you have this happen 16, 17, 18 times in a month, you can still submit a complaint about that and saying, hey, there's this pattern here. That can be taken under consideration by our office.
Where it's a pattern of requiring overtime work in a non-emergency situation.
Exactly. So some additional specific information needed for some other areas that we see complaints about. For complaints about not having a nurse staffing plan, We would want to know how long has the unit been without an approved nurse staffing plan, again, to the extent of your knowledge. Like, I know that we've gone for over a year without an approved nurse staffing plan, something of that nature. If you have a complaint about not having a nurse staffing committee co-chair or a unit representative, we would need to know, again, to the extent of your knowledge, how long has this vacancy existed? And for complaints about direct care members not attending the nurse staffing committee meeting, we would need to know, was the member released from their assignment for that meeting, or were they required to continue working? So we're going to go on to our nurse staffing myths. Our first myth, and perhaps I think maybe one of the most common ones, is that our office sees the staffing request documentation forms, known as SRDFs, / the assignment despite objections of those ADOs, submitted to the hospital and the union. The fact is, OHA only sees those documents when they are submitted to our office as part of a complaint. So any sort of routine submission that you're doing to your union and the hospital, we don't see those unless someone directly sends it to us. Similarly, submitting an SRDF or ADO provides OHA with the information they need to start a complaint investigation. The fact is, SRDFs and ADOs rarely have all of the information OHA needs to initiate a complaint investigation. Although we do accept those SRDFs and ADOs as part of a complaint, it is highly likely that we will need to return to the complainant with requests for more information, which is ultimately going to slow down that complaint process.
And I will also say, sometimes we have unions that submit a whole batch of SRDFs. We then need to contact each individual who completed one to find out, did they want to file a complaint, and then to ask those follow-up questions, because again, those forms don't have enough information for us to move forward and determine if we can even investigate.
So these next two myths are in the form of statements we've heard. After I submit a complaint to OHA, OHA will investigate my complaint. The fact is that we are required to review the complaint to identify areas of concern and confirm that we have jurisdiction. This process often requires us to ask additional follow-up questions. So like Anna mentioned earlier, we need that specific allegation. If we have a complaint that people miss meal and rest breaks all the time, that's not enough for us to be able to have the specific information we need to start a complaint investigation.
So we're going to reach out and we're going to ask more questions. And we'll generally give you a timeline for when we need responses to that. If the responses come late, we'll reopen it, and we will, again, continue that conversation with a complainant to find out the information we need.
Yes, and I think what you're getting there Anna, is that if we give you a timeline to respond and we don't hear anything, and then we don't hear anything, and we don't hear anything, we eventually do need to close that out of our system. You will get a letter saying, we tried to get more information from you, we didn't get the information we needed, so we're closing this now. You are allowed to reach back out and say, hey, here's that information. And then we will reopen it at that time. We can reopen complaints. We just can't have them sitting around in our system as open for months and months and months. Another myth that we hear is the 60-day timeline to investigate my concern begins when I submit my complaint. And so where that's coming from is that OHA is required to investigate complaints within 60 days, but that timeline begins when OHA determines that the complaint has an allegation within OHA's jurisdiction. So after our triage team has been able to look at it and say, okay, I see what that allegation is.
So when we have enough information. So if we get a complaint that doesn't have enough information, that 60 days hasn't started yet, we're still trying to get that additional information.
Another myth is a complaint should include all known instances of non-compliance, such as all known instances of missed meal and rest breaks. We're really doing the meal and rest breaks a lot today, I'm noticing. The fact is, the complaint can include information about a single incident or multiple incidents. Ultimately, it's more important that the complaint reflects all necessary information for a single incident than all known incidents with incomplete information. Because again, we will look at a sample when we go there. And so it's important that we have one specific incident that we can work off of to start a complaint. Another myth is that complaints must be submitted the day the incident becomes known. For the purposes of our office and for the purposes of OHA nurse staffing complaints, that is not the case. Complainants can submit complaints after that incident occurs, and we encourage you to take the time that you need to gather all information required for a complaint. And again, it can be about a single incident. It doesn't need to be about all known incidents.
That said, a complaint that's submitted more than a year after the incident is unlikely to, federally, the federal complaints that are more than a year old, we don't investigate. In terms of state, we would be less likely to investigate those.
Yes. Another myth is that OHA interviews the nurse staffing committee co-chairs and direct care unit representatives as part of the complaint investigation. This myth, I think, again, is coming from the fact that for those nurse staffing surveys, that is what we do. We do talk to the nurse staffing committee co-chairs, both the direct care and nurse manager, as well as the direct care unit representative for the full nurse staffing surveys.
And that's actually required by statute that when we do those full surveys, we speak to the staffing committee co-chairs.
But for complaint investigations, since those have that narrow focus, they're primarily relying on record reviews with limited interviews of individuals who have direct knowledge about the underlying facts of the complaint.
So we could theoretically speak to a co-chair if they have personal knowledge of the underlying incident. Most often they don't, and so they are rarely interviewed in the complaint investigations.
Another myth is that OHA can investigate other areas of the nurse staffing law besides what is covered in the complaint. Again, complaint investigations are narrowly focused on areas related to the underlying allegation. If we incidentally discover non-compliance, it will be cited in the report. However, complaint investigations are not as broad and extensive as full nurse staffing surveys.
Now we're going to move on to our Q&A. We have a couple questions that we got in advance, and we have questions that people are submitting now. So one of the questions from right now is asking us to clarify the minimum numbers on the staffing grid or not. If you're dealing with a unit that has CNAs, then the nurse staffing plan needs to address what is the minimum for CNAs. So for each kind of nursing staff member, RN, LPN, CNA, that nurse staffing plan should indicate, do those nursing staff members work on the unit and how many for each minimum. So a CNA can't work in place of an RN, so that nurse staffing plan would say, we have to have 4 RNs and 2 CNAs. Now, theoretically, an RN could be doing the work of a CNA, but you can't work above your license. So if you had a CNA call out sick and an RN volunteered to take that shift, you could work that shift that was supposed to have 4 RNs and 2 CNAs with 5 RNs and 1 CNA. But if you had an RN call out sick, you couldn't work it with 3 and 3.
And then that question also asked about charge nurses as it relates to being in that minimum number. I will say, if that charge nurse does not have a direct patient assignment, you may run into, and you're planning to use them for meal and rest break coverage, you may run into problems if you put them in your nurse staffing plan, because the second they go and cover for someone else, you now no longer have your minimum number for that charge nurse.
Exactly. So another question is, what is the acceptable % for missed meals and breaks if the unit meets minimum staffing? We actually don't have an allowance for a % of missed meals and breaks. The statute doesn't give us that, and we haven't had that recommended by the board. That would be an interesting question to discuss with the board, but there isn't an acceptable % of missed meals and breaks. The expectation is that hospitals' nurse staffing committees will come up with a nurse staffing plan that provides adequate coverage for meals and breaks and ensures that the unit will keep their minimum numbers during those meals and breaks.
So one of our early bird, what justifies a complaint? So this is really any violation of the nurse staffing rules. And so that's getting into those webinars that we've already had, as well as the webinar we'll be having next week about the nurse staffing committee. So any potential violation of those nurse staffing rules. Minimum numbers is a common one, meals and rest breaks, mandatory overtime, and units not having a nurse staffing plan, or adopting a tool, a different process than what is approved in the nurse staffing plan, are all things that we commonly see. I'm trying to think of some areas that people have reached out to us about, Anna, and we have to tell them that's not usually us. Retaliation, I think, has come up a couple times.
That's true.
That's under there is, I will say, there is anti-retaliation provisions in the nurse staffing law. This is one of the few parts of the nurse staffing law that is not within our jurisdiction, though. It goes under the Oregon Bureau of Labor and Industries, so bully. It's what I call them.
Also, here's another one. Here would be a complaint that would not be us. I get my meals and breaks, but I don't want to take them as early as I do. I want to take them later in my shift. When you take your break is a bully question. Our question is, did you get the meals and breaks you were supposed to get? But the timing of those is all about bully.
Another one that I've seen more frequently, actually, the hospital not following the union contract. Excuse me. We cannot enforce your union contract. That is not under our jurisdiction. So that would not be a complaint that we would be able to act on.
True. Okay. How does OHA become aware of staffing violations?
We only know about those if they're submitted to our office, and we can put our email address in the chat. If it's not sent to us, we're not going to know about it. We can find out about it during we can find out about violations during a nurse staffing survey or another complaint, like we mentioned during a complaint investigation. If we're doing a complaint investigation about minimum numbers and we incidentally find out that the nurse staffing committee hasn't met it for a year, we're not going to ignore that. That's still going to end up being a citation. But if you're submitting ADOs and SRDFs to your union, we're not going to see those or not know about that underlying complaint unless someone reaches out to us.
We have a question. What happens when a nurse is reaching her 1 hour, 1 hour of mandatory overtime and doesn't want to stay after that, but knows there's no additional staff coming on shift, so the burden will fall on her coworkers to absorb the patients? Should this really be counted as creates a risk of harm to a specific patient, or where there is a vacancy in the next shift that became known at the end of the current shift? So a vacancy that has been known for weeks, somebody is now out on OHA FEMLA leave, that's not a surprise vacancy. That wouldn't be mandatory overtime that would be permitted. That 1 hour mandatory overtime is permitted in those two narrow situations. Otherwise, if you're being required to stay because somebody's out on OHA FEMLA and you do not have a choice, then that is mandatory overtime. But if your manager says to you, well, we really need you, will you please stay? And you say yes, that's voluntary.
Yes, if you have that option to say no and you say yes, then that, like Anna's saying, that's voluntary overtime and we don't have the basis for a mandatory overtime complaint. I see a question here asking about the impact of the nursing shortage and how that's impacting our complaint investigation process. I will say we did discuss last week that there are, I'm trying to think of summarizing this conversation, but we were talking last week about emergencies and certain emergencies that allow you to deviate from their staffing plans. For example, we had COVID. That was a federal and state emergency declaration. And if a hospital had their facility disaster plan, and as of 2022, crisis standards of care in place, that would have allowed them to deviate from those plans. We do not have a state or federal emergency declaration for nursing shortages. So the hospitals do not have the ability to deviate from their plans. And so if there is that deviation, nursing staff members can still submit complaints if they're not getting meal and rest breaks, if they're not meeting minimum numbers, that's still able to be submitted.
So what happens when complaints are investigated and they are unfounded? In that situation, we would, our report would reflect that we did an investigation and the allegations were not founded. We would send that out to the complainant and the hospital, including the CNO, the administrator, and the nurse staffing committee co-chairs. I will say there have only been a few, it's really not a large number where it's been unsubstantiated. And I will also note, in our general experience of healthcare regulatory work, what we have found is even if a complaint is unsubstantiated, the fact that we came in and did that investigation and brought attention to the issue often has an impact on the facility operations.
Yes. And so I do see a question, I see two early bird questions that really tie into each other. One is asking about how complaints are investigated, and one is asking about what is going to trigger that in-person, on-site investigation. And so that first aspect of it, during the pandemic, we have been conducting complaint investigations remotely. And so prior to the pandemic, those were conducted on-site, but since I think August 2020, we've been doing that remotely. We do reserve the right and the option to do an in-person complaint investigation. So far, that's only been for when we're combining it with a full nurse staffing survey, but depending on the nature of the allegation, we also would be able to do an in-person standalone complaint investigation. And I'm trying to think, Anna, of situations where that might be necessary, because a lot of what we get from nurse staffing complaints really can be done remotely.
Yeah, I think it would be a case-by-case situation, but it does not. I haven't seen it come up. And one of the things I do want to note about that is if we felt the need to interview direct care staff members, we would probably not want to do that on site at the hospital, because that wouldn't maintain the confidentiality. So we'd probably rather do that using Zoom or Teams, so that we're not in the hospital and having the hospital administration able to see who's coming in and out of that interview room.
Mm-hmm. We do really feel strongly about protecting the confidentiality of our complainants to the extent permitted under law.
So we have a question: if the staffing committee investigates a variance, does this need to be reported to the OHA? There's no requirement that it be reported to the OHA. And by variance, I assume we mean something where they didn't meet minimum numbers, they were not complying with the staffing plan. It doesn't have to be reported to the OHA, but it can be reported to the OHA. Even if the staffing committee has investigated and addressed it, it can be reported to us and we could investigate it, because it is a violation of the law. And in that situation, if it was something that the committee had already looked at and they'd already put a correction in place, that might be what gets put into their plan of correction if we find non-compliance.
We have a question here about procedural units that has closing time. What if toward the end of the shift, so towards that closing time, the staff realize that the patient will not discharge in time? Is it allowed mandatory overtime if the staff members have to stay until the patient discharges? So that's roughly 1 to 2 hours over the previously agreed upon shift length. There's only 2 situations in which that can happen. if there's a vacancy known at
The next
first
shift,
which isn't going to happen.
Which isn't going to happen because this unit doesn't have a next shift that's immediately following.
And the other option is if there's going to be patient harm, if they leave their assignment or transfer assignment to someone else. But that's only for up to 1 hour. So if it goes into 62 minutes, 63 minutes beyond that 1 hour, then that's, and it's being required as a condition of employment. No one's volunteered to keep working. That's going to become mandatory overtime.
That's why many procedural units do have those call shifts that
Yes.
follow the shift, because then you can get that call team to come in and take over. In some situations that might not be possible for patient care purposes. And then if it goes past that first hour, then that would be mandatory overtime.
And the basis for a complaint.
And when we're talking about those call shifts, if the nursing staff members can choose when they do their call shifts and they have selected to work that call shift immediately following their shift, then that's voluntary overtime. If you had a shift, it was supposed to end at 8 p.m. and you voluntarily signed on for a call shift beginning at 8:01, then the fact that your procedure didn't end at 8 p.m. and you kept on working until 10:30 p.m., well, that was part of your call shift, that 8:01 to 10:30. And so that is not mandatory overtime, that's voluntary, as long as you were able to pick that, yes, that was the call shift you wanted.
Now, if the hospital said, hey, we noticed that you're in that last shift of the day, you're ending at 8, you now get that call shift immediately after.
And you have no choice.
Yes,
no
you
trades.
have that. No trades. No takes back fees. That could be mandatory overtime.
Yes. So if a staff member stays over for 15 minutes, does the facility have to document whether it's mandatory or voluntary for only 15 minutes? And
Yes.
what I would say is undocumented is undone. We want it documented because generally, if it's less than 15 minutes, we would not be citing a hospital. But if it is repeated over and over, we're seeing it happen day after day after day, we are going to cite it. And therefore, we do need to see, was that voluntary or mandatory? Because if it's 15 minutes of mandatory day after day after day, that's going to get a citation.
Yes. For all of this nurse staffing stuff, all of the nurse staffing requirements, you want to document to show that you're maintaining compliance with the nurse staffing rules. So it's really important to document voluntary versus mandatory and to have all of the documentation in your nurse staffing committee meeting minutes, which we'll get into next week, documentation for nurse staffing plans. It's really important to maintain all of that for situations like this. When we have a complaint investigation and we need to go in, we need to know and be able to see that documentation. Because if you don't have the documentation, that could become a citation where we say, look, people are working overtime again and again and again and again, 15 minutes past, 20 minutes past. And the hospital does not have the documentation to show whether that's voluntary or overtime or mandatory overtime. That is frequently how those citations for mandatory overtime work, where the hospital doesn't have the documentation to show if it's voluntary or mandatory.
We did have a question, can we make a mobile app to facilitate this more easily? And what I would say is that might be a great idea. We don't have the resources for it. And I will tell you, with my vast experience being trained as a lawyer and Kimberly's vast experience with a master's in public health, we're the people who maintain the website. I built the nurse staffing website, we maintain it. I unfortunately have not learned to build apps, and we don't have that capacity within our program. So I think that is an unlikely addition.
I'm real good with an Excel spreadsheet, but give me an app and it's gonna get messy. It's gonna be a worse process for all of us if you have me trying to build an app.
Yes. So we have a question about how do we follow minimum numbers on a unit that has flexing minimum numbers of staff?
I'm gonna stop you before we get too far into this one. if we're talking about flexing minimum numbers, my ears are pricking up and I'm already getting concerns. Minimum numbers, as we've discussed in the nurse staffing webinar, that is the absolute minimum number. You do not drop below that. And it needs to say for what shift and for any given patient population or patient number you've got on that unit. So if you've got a 20-bed unit, I should be able to walk into your unit and say, okay, day shift, 17 beds are filled. How many RNs do we need? How many LPNs do we need? How many CNAs do we need? That we cannot drop below that number.
And so if your matrix said, we need 6 to 8 RNs, what we would say is
it 6 or 8?
Exactly. How do we know?
Or 7.
Or 7. How do we know? Your plan should be telling you it is 6 or it is 8, but not it's somewhere there, because
in between. Yeah.
Because if we can't tell, very likely staff can't tell either. Is this a 6 or an 8 day?
Mm-hmm. And you can always, or 7. We keep skipping over 7. You can always staff above that minimum number, and it would be appropriate to if that unit has a high overall acuity or a high overall intensity. That minimum number is that number of, we, under no circumstances, if we are at like 17 patients, that's my favorite number today, I guess. If we're at 17 patients, we're not going to ever drop below this number of RNs, this number of LPNs, and this number of CNAs. And so if you get to a situation where you do drop below that and below what's in that plan, that becomes the basis for a complaint.
So that question, before we jumped in to say, oh, flexible, it continued to say, what if a unit, sometimes overflow patients come and there's a different ratio, and sometimes you need a CNA. If they're all ICU, then a CNA wouldn't be called for. And what I would say is your nurse staffing plan needs to reflect all of those possibilities and say, if we have 5 patients, but one of them is an ICU patient, this is what our staffing should be. And if we have 5 patients and there aren't any ICU in there, this is what our staffing needs to be. And then that question also included the word ratio, and I would always flag that and say, ratio is not something in the law, it's not something we enforce. We're looking for that minimum number.
And indeed, if you have a ratio, that would result in a citation if we saw that, because it needs to be a number and it can't be a ratio.
So we have a question, if minimum staffing levels have been defined, but on a particular shift, the acuity and intensity is exceptionally high, and a request for additional staff was requested or was made, and then not fulfilled, would this be considered a violation of the staffing plan? The staffing plan minimum should be reflecting acuity and intensity. So if you have your staffing plan correctly built, it should reflect not just the total number of patients, but what is the acuity and intensity of those patients. Both what is the severity of their symptoms and what is the intensity, the amount of direct time they need, which can be a result of their sickness or can be a result of other factors, such as lots of family drama, a minor patient in an area where minors are not usually treated or seen, in a procedural area, for example, where minors are not usually part of the patient population, or a language barrier that requires some additional resources. All of that is intensity. So your nurse staffing plan should reflect that and should say, for this unit with 5 patients at this acuity and intensity level, this is what our nurse staffing is. But when the acuity and intensity is higher, it's this level, then we have a different minimum.
And so I'm such a visual learner, so I am like drawing it out over here and then realizing no one's, like with my hands in the air and realizing no one's going to see that. So I imagine what you're envisioning here, Anna, and what you're telling people is essentially we'll have columns for RNs, LPN, CNAs. We'll have a primary column, I guess, for what that census number is going to be. You're going to repeat that for like low, medium, high, low, whatever that score is going to be.
Low acuity intensity.
And acuity and intensity are separate things. So you can
Yes.
perhaps combine that into a single score, but they have to be measured, both of them, because they are separate things. So then low, medium, high. And that's what I'm envisioning. So I wanted to, again, visual speaker here. So
if your plan has a minimum and you're meeting that minimum, but you still feel like, wow, we still don't have enough staff to meet our patient care needs, then that's telling me it's a good time to talk to the staffing committee and say, this plan isn't doing what we need it to do. Let's look at some of those factors we're supposed to look at in plan reviews and figure out why we keep feeling understaffed on this unit. But if you have actually met your minimums and your plan has all the elements, then we wouldn't find a violation of the minimums.
And so in that case, we wouldn't be able to have, we wouldn't have a complaint that we would be able to act on.
And
if you're meeting your minimum.
If you're meeting your minimums, and that might be something we discover in a complaint investigation, or we might determine that before we even begin an investigation, when you say, well, our minimum is this, and that's what we had, but we still felt short-staffed. So the question is really, at that point, well, is your staffing plan meeting your needs? You need to review it once a year with the requirements for the review, and there are specific factors to look at in the review, but that staffing plan can be reviewed anytime during that time. It can be reviewed early if it's really not working.
And you can update, you can do that update at any time. And if you say, okay, we know already that we want to, for example, switch out our acuity tool, you can do that and switch that out at any time without doing that full giant annual review. I say giant, but it's not that giant.
I will also say one thing that we see hospitals do is having trials. Let's trial another plan. That's totally fine. If you're going to do that, that trial needs to be approved by the nurse staffing committee. You cannot implement a trial that has not been reviewed and approved by that staffing committee. That would be something that we would cite.
And Anna, I will just point out that we are fastly approaching 11 o'clock.
Yes. We do want to respect your time. So we have one more question to answer.
Someone just submitted one. So it says, can a staffing committee reject an SRDF if minimum staffing was met, but the staff still felt understaffed? So those issues of SRDFs, they are not for us. We will accept them because we will accept any complaint that is made to us. We will accept, and we will look to get more information for it. But when someone is submitting an SRDF to you and
as the staffing committee,
that is a separate process for you to do with as you will. I will say, if someone is submitting an SRDF saying, yeah, we met minimum numbers, but we still feel understaffed, that might be a cue to the nurse staffing committee that nurse staffing plan may be updated.
I think that's very similar to that last question. If the staff, if you're meeting your minimums, but you still feel like we're working flat out, we're not able to meet patient care needs, then that is a sign that your staffing committee needs to review that nurse staffing plan, whether or not that SRDF results in some specific action. It's a time to say, let's review this plan. The plan isn't working. Our very last question, then we're going to jump to our last slide, is will these slides be emailed to attendees? They won't be emailed to attendees, but they will be available on our website. That'll get posted next week, definitely by Wednesday.
I've been aiming for a goal of Monday and Tuesday. I've met it most of the time, but I have never been past Wednesday. So
okay, along with actually this whole webinar. So if anyone, if you know somebody who missed it and wants to listen in, all of our webinars are posted on the website, and the slides are also posted separately. And we have one last question, is buddy breaking allowed? I would refer to the meals and breaks webinar we did, where we went into great detail on when that might be permissible and when it isn't.
And I will say, those are all, like Anna said, it's posted on our website. It hops you to YouTube, where you get that fun feature of playback speed. And so you can listen to us quickly. I know that people are short on time, so that is an option.
Or repeat something that you didn't quite catch.
Very cool.
Okay, so up on the screen now, we have a list of the webinars we've done so far and the one next week on nurse staffing committee requirements, which will wrap up this series. And then we have our nurse staffing resources. Again, we have that healthoregon.org/facility complaints, where you have that complaint form, and healthoregon.org/nurse staffing, which is our main nurse staffing website. Other things to look at for this specific webinar: the nurse staffing interpretive guidance has a whole section on complaints. That's up on the website. And always the nurse staffing reports and approved plans of correction. And you can see those, and in fact, on where we have all those reports, you can see, was this a complaint investigation, or was this a survey, or was it a combination of both? And again, we have our website, our email, so that if you have additional questions, you're always welcome to mail us at mailbox.nursestaffing@odhs.oha.oregon.gov. And with that, we will thank you for staying 1 minute over and for joining us. We hope you'll join us next week for our nurse staffing committee requirements, the last webinar in the series.
And I will say, if you have a friend who is interested in this, hasn't been able to attend, they can still register. So registration is still open for anyone who may be interested.
Thank you.